This is the tissue integrity recording for care of the patient with chronic conditions. Pressure ulcers. A pressure ulcer is a localized area of injury to the skin and/or underlying tissue, usually over a bony prominence, as a result of pressure or pressure in the combination with shear. Pressure ulcers, you might also hear them called bed sores or decubitus ulcers, or a pressure injury. Prevention of pressure ulcers are essential to safe patient care. Comprehensive skin assessment identifies those factors increasing a patient's risk for pressure ulcers. Once a pressure ulcer occurs, there are specific treatments to promote healing. Principles for practice. They occur from unrelieved prolonged tissue compression. Pressure ulcers occur from unrelieved prolonged tissue compression, which interferes with blood flow to the tissue. If this compression continues for a prolonged period of time, the tissue dies from lack of blood flow or tissue ischemia. Ischemia develops when a pressure ulcer on the skin is greater than the vascular pressure on the inside of the vessels, causing the vessel to collapse, decreasing tissue perfusion. So if you point your finger and your thumb, squeeze them together pretty tightly, and then you release them, you see that they're white and then they turn pink again. So essentially you put enough pressure to compress those blood vessels to push the blood out, decreasing the blood flow, but as soon as you release it, that blood flow returns. So the same thing's happening with a pressure ulcer. Whatever area that this person is laying on for a prolonged period of time, it eventually comes to a point where the pressure from them laying on that area, and this is why it happens on bony prominences too, because between the bone and the tissue and whatever surface that person is laying on, it creates enough pressure to compress the vessels and creating a tissue ischemia. So the tissue isn't getting all the blood and the oxygen and the nutrients that it needs, and it eventually will die. The most common sites for pressure ulcers include the sacrum, coccyx, ischial tuberosities, greater trochanters, heels, scapula, iliac crest, and lateral and medial malleolus. So we mentioned pressure ulcers occurring on areas where there's bony prominences. So what about other pressure ulcers that aren't necessarily like from bony prominences? Can you think of anything else that might cause a pressure ulcer? So what about like if somebody has oxygen tubing on and it's creating pressure on their cheeks, that could cause a pressure injury on their cheeks. Or if that tubing is pulling tightly on the backs of their ears, that can also cause a pressure injury on the back of their ears. So pressure injuries can occur on areas of the skin subjected to pressure over non-bony locations due to poorly positioned or ill-fitting devices or incorrect use of devices. These types of injuries are called medical device pressure ulcers and are due to prolonged unrelieved pressure on the skin from medical devices. Review the Perry and Potter highlights in its page 990. These are also copied and pasted to a Word document and up in Blackboard. So pressure ulcer sites, these are some common sites. So you have the occipital bone, scapula, spinous process, the elbow, iliac crest, sacrum, ischium, Achilles tendon, the heel, the sole, and then we have the ear, side lying, possibly the shoulder. We have the anterior iliac spine, the trochanter, the thigh, the medial knee, so the inside of the knee. If you're lying on your side and for some reason this knee might be causing pressure with the other knee, but the inside of the knee could cause pressure injury if there's enough pressure being put on that inside of the knee to collapse the blood vessels and impede blood flow. The lateral knee, the lower leg, the medial malleolus, so inside of your ankle, the lateral edge of the foot, and the posterior knee. So the back of the knee, if you're laying on your side, I'm trying to picture a situation where I could see something happening to create pressure there, and that's a little bit, I'm trying to, on their side, on the back of the knee, I don't see it as much as I do when you look at the wheelchair. The back of the knee on a wheelchair seems that could pretty easily create an area of pressure where it's going to impede that blood flow. Also looking at the wheelchair, we have the sole and the ischium and the sacrum, and then that spinous process. So just take a look at these areas and think about it, like when this person's laying in the back of on the bed, what areas are going to have more pressure? When they're laying on their side, what areas are going to have more pressure? And then the wheelchair. And what if we do discover an area where there is that red non-blanchable skin, that stage 1 starting to occur? The first thing that we do is we take our patient off of that side to alleviate the pressure. So we start to reduce pressure in that area. And what I mean by non-blanchable, it's that you kind of can palpate, you see a red spot and you palpate it and it stays red. It doesn't turn white then red. Principles for practice. Factors to formation. Chronic moisture, excuse me, from incontinence. Shear, immobility, loss of sensory perception, decreased activity, malnutrition. Stages of pressure ulcer, page 991 from the Perry and Potter book. That is also on the Word document that is copied and pasted up in Blackboard. So medical devices or medical device related pressure ulcers are defined as pressure injuries resulted with the use of devices applied for diagnostic or therapeutic purposes. These pressure ulcers cause pain, loss of function, increased length of stay, and increased healthcare cost. Timely assessment for actual device-related pressure ulcers provides prompt prevention and treatment. Shear can damage the skin in one of two ways. Shear stress, defined as the force per unit exerted on a parallel to the plane of interest, and shear strain as defined as distortion or deformation of tissue as a result of shear stress. Shear stress can result from skin tears, shearing of the epidermal layer of the dermis, such as inappropriate tape removal, and deep damage such as pressure ulcers. Shear strain occurs when the subcutaneous tissues shear against the dermal layer, distorting blood vessels, such as when the patient slides down in bed. Deep tissue injuries can occur in these instances. Immobility often restricts a patient's ability to change and control body position, and thus increasing the pressure over bony prominences. So if the patient cannot move, they're not going to be able to reposition themselves and alleviate that pressure from being in that same position. Loss of sensory perception decreases the individual's ability to respond to decreased prolonged pressure in an area and change the body accordingly. Level of activity refers to the person's normal physical movement. A person who is bedbound is at greater risk for skin breakdown than a person who is fully or partially mobile. Research indicates that malnutrition contributes to the development of pressure ulcers. Pressure ulcers pose serious risk to a patient's health, and breaks in the skin can be seen in stages 2 to 4. Pressure ulcers eliminates the first line of defense for the body against infection. When pressure ulcers develop, explore factors that are contributing to the skin breakdown and vigorously attempt to minimize the effects of these variables, and use current wound healing principles in the management of pressure ulcers. Evidence-based practice. Perform and repeat risk assessments regularly, as frequently as required by the patient's condition. So you follow your facility's protocol on performing these skin assessment risks. For sure, upon admission, and dependent on what your scoring is for the skin assessment risk, that'll tell you when you need to do it again. Document all risk assessments. So we do the risk assessment, and we don't just like complete a braid-in and then start to, okay, we're going to turn this patient every 2 hours. We want to document that we completed that braid-in. Use risk scores to plan care and perform interventions accordingly. So based on what the score we get, it'll tell us what interventions we're going to need. An ongoing skin assessment can detect early signs of pressure damage. And of course, alleviate the pressure. If you identify an area that is getting a lot of pressure, or you're starting to see pressure ulcers starting to develop, get that person off of that area, alleviate that pressure. Take them off of that area. When we use the risk assessment scores to further identify at-risk patients, such as patients with that non-blanchable arrhythmia, urogenital disorders, and high body temperatures. In individuals of high risk of pressure ulcers, conduct a comprehensive skin assessment as soon as possible within 8 hours of admission. So if you do a braid-in and it shows that they're at high risk for pressure ulcers, you want to do that skin assessment as soon as possible, just to make sure they don't already have any pressure ulcers, and to identify any areas that you are seeing getting red to avoid getting pressure ulcers. The use of hydrocolloid dressings as part of ulcer prevention, and also can help reduce the risk of medical-related pressure ulcers. Medical devices are commonly used in the hospital, can create pressure. Humidity and heat to develop between the device and the skin. Change in the microclimate of the skin. Prompt and routine assessment of the skin under the devices in reducing the risk of pressure ulcers. And identifying early stages of skin breakdown and prompt interventions. So we always want to be assessing, and when we identify somebody who's at risk, we do the interventions like turning, and anytime that we see somebody at risk, we want to promptly intervene. The Braden scale. The Braden scale is used for predicting pressure ulcer scores, is a clinically validated tool that allows nurses and other healthcare providers to reliably score a patient's level of risk for developing pressure ulcers. If not done upon hospital admission, Medicare will not pay for the treatment because it is an initial skin assessment was not completed. So it is assumed that the pressure injury was caused by improper care at the hospital. So we do the Braden score, and they score very high, or if it's not even done at all, they're going to assume that the pressure ulcer occurred at your facility or at your hospital. So you want to do that skin assessment, and you want to do that Braden score right away. So if that person does have a pressure injury, that it's identified, or if they're at risk, it's identified. So that it doesn't look like it occurred at your facility if it already exists. Quick quiz. A 49-year-old woman is recovering from a pressure ulcer on her left hip. The patient refuses her lunch and tells the nurse that she is fasting at lunchtime as part of her weight loss plan. How should the nurse respond to the patient? The nurse should explain to the patient that fasting is against the hospital policy. The nurse should scold the patient for her choice of diet. The nurse should inform the patient that fasting will hinder her healing process. The nurse should respect the patient's choice and not say anything. So the correct answer is C, and the rationale is adequate nutrition helps to prevent the treatment of pressure ulcers. A diet high in protein with enough calories, vitamins, and minerals maintains normal healthy tissue status and promotes healing. With tissue injury, the body needs more calories for healing. Nutrient deficiencies may impair or delay healing. So safety guidelines. Know the cause or type of wound. So know what kind of wound that we have. Is it a vascular insufficiency wound, diabetes, ulcer, trauma, surgery? All are very different and have individualized treatment plans. Not knowing the cause of our wound can have serious negative effects in treatment that are contraindicated for certain type of wounds. Identify appropriate wound cleansing agents. Not all agents are ideal for every single situation. Know the expected amount of wound exudate or drainage. Wounds with large amount of drainage require more frequent dressing changes or need an a dressing that is very that can absorb a lot of exudate. Determine if wound drainage tubes are present to prevent their accidental dislocation when removing the old dressing. So we want to know if our patient has a drain so that when we take the tape off and we take the gauze off, we don't pull the drain out. And also any drainage, we want to make sure that any drainage containers or tubes, we want to make sure they're positioned in a way that they're not going to cause any pressure injuries. Wound care. Proper wound care is necessary to promote healing that results in intact skin layer. Intact skin is the body's first line of defense against invasions by infectious microorganisms. The skin defends the body in other ways by serving as a sensory organ for pain, touch, temperature, and it has an acid pH, which is often called acid manadil. The skin defends the body in other ways as serving as an organ that senses pain, touch, and temperature. It plays a role in thermoregulation, metabolism, immunity, and fluids balance regulation. Wound care. Cleanse from center to outside or top to bottom. So top to bottom for surgical wounds. That's something that, that we should highlight. And then we always want to cleanse from center to outside. If we're cleaning from the outside in, could be possibly bringing stuff from the outer part of the wound or from the top of the skin into the wound bed. And surgical wounds are from top to bottom when you're cleaning them. Use multiple cotton-tipped applicators or gauze if necessary. If my thing is dirty and it's better just to get a new one than if you think it's really saturated with exudate instead of using the other side. If in doubt that the other side is clean, just get a new one. Use as many cotton-tipped applicators or gauze that you need to use to do a good dressing change. Saline is going to be your most effective cleanser. Use gloves as personal protective equipment for most dressing changes. Use additional personal protective equipment if there could be any potential splashing. So intact skin is the first line of defense of the body against invasions by infectious microorganisms. And then like other dressing changes just to think of with personal protective equipment. If I'm doing a sterile dressing change, like a PICC line dressing change or certain surgical dressings, in addition to my gloves, I need to wear a mask. So when I remove the old dressing, I'm not breathing or coughing on that wound. But most of them will, if it's not like a sterile or dressing change, most dressing changes will only require gloves. But if you're concerned about like you're coughing or breathing on the wound or the insertion site, you'll use a mask. And if there's going to be splashing, like if you're changing something that might be messy, you might need a gown. And then possibly eye protection too, if you're going to change a very messy wound that could possibly splash. Evidence-based practice, wound debridement. Debridement is the removal of non-viable tissue from the wound and is essential so that the wound can heal. Enzymatic debridement is the topical enzyme over the necrotic tissue. Mechanical debridement is like when you do a wet to dry dressing. So when you put that wet saline gauze within a dressing and you allow it to dry, and then you remove that gauze from that wound, it's going to rip out all of the dead tissue. The problem with that is also takes out newly healed or new tissue. Autolytic debridement is the use of like a tegaderm over a wound, and you're trapping your body's own enzymes in there and allowing that to like soften the slough, and then it'll come off. Sharps debridement is going in and cutting out necrotic tissue with like a scapula, scissors, and using tweezers. Chemical debridement should stop after the wound has started to heal to avoid damaging tissue that has begun to heal. Central line, the correct steps for performing a central line dressing change is as follows. Don a mask and have the client don a mask, remove old dressing, remove and discard gloves, perform hand hygiene, cleanse the site, apply a new dressing. The care of a central line dressing involves ensuring sterile technique and replacement dressing when needed. A clean and intact dressing may be left for 7 days. A gauze dressing for a central line needs to be replaced every 48 hours, even if the dressing is dry and intact. Scrubbing the insertion site with antimicrobial solution for 30 seconds and placing an impregnated antimicrobial dressing on the insertion site are both correct actions in caring for the patient with a central line dressing. So we want to clean it either with our chlorhexidine or our alcohol and iodine, and that little antimicrobial patch, that one that we put with the blue side up, that is correct. Those are good standards of practice in preventing infection in central line dressing changes. Central line dressing, when maintaining the client's central line, the nurse will use a 10 ml syringe instead of a 5 ml syringe because smaller syringes can exert too much pressure, which can damage the catheter. The nurse will wipe the access port with an antimicrobial swab for at least 30 seconds. So the access port, or the needle-free port, sometimes you'll hear it called. We're cleaning that with alcohol for at least 30 seconds. And we will flush the catheter before and after each medication. And we're using that push-pause motion. And the rationale for our push-pause motion is that it creates turbulence within the line, better clearing that line of any residual medication and making sure that it's completely flushed. Transparent dressings, you can use these on skin tears and stage 1 pressure ulcers. You walk the dressing over the area, avoiding wrinkles, and what we mean by walk is you're just kind of like smoothing it across the skin, and you're trying to avoid any wrinkles in your application of that transparent dressing. The dressing maintains a moist environment that uses the body's own enzymes, so that autolytic debridement, your body's own enzymes. Liquid film form protective barrier wipes. So Skin Prep is a brand name. Should only be used on intact skin. Helps tape and film adhesion. Forms a protective film to help reduce friction during the removal of tapes and films. So Skin Prep is definitely something that you want to use on your elderly patient's skin, and anybody's skin. You help protect their skin and it helps everything stick better, but especially people with that risk for like skin tears or those shear injuries, such as our elderly clients. Hydrotherapy is the external use of water in the medical treatment of certain diseases. Most burn units and hospitals have hydrotherapy rooms. Hydrotherapy softens and removes dead tissue, enabling new, healthy tissue to form and promote healing. Hydrotherapy for burns can start within a few days of trauma once the patients have recovered from the initial shock of their condition and have been stabilized. Spiral bandages, ankle support, knee support, wrist support. So two circular turns are used to anchor the bandage. So two circular turns are used to anchor the bandage. And finally, two circular turns are utilized to complete the bandaging process. And they're usually not applied directly over the wound. Oh gosh. They are usually not applied directly over the wound because of the discomfort they may cause. So if my ankle is the part that's injured, wrapping around twice, then wrapping around again, and I'm avoiding the actual injured area to avoid discomfort. Spiral elastic bandages. When wrapping a limb, wrap from distal to proximal. So I'm doing spiral turns. It looks like this one. We started at the wrist and we're wrapping up towards the elbow. So the wrist being distal and like the elbow being proximal. So let's look at something else. Like what if I had to wrap somebody's calves because they had a bunch of edema, or anyhow, let's say we had to wrap their calf. Yes, their calves. So we would start at their ankles and work up towards the knees. If you had to wrap somebody's thigh, you would start at the knees and work yourself up towards the greater trochanter. Wet to moist dressings. This is our steps in this procedure. Perform hand hygiene. Remove the old dressing with clean gloves. Perform hand hygiene just because it's an old dressing. Open the package. Moisten the gauze. Apply sterile gloves. Press and moisten fluffed gauze into the wound depressions. Apply sterile ABD pad over the moistened fluff gauze. Date and initial and label prior to applying it to the dressing. So on this, just some things to think about when we're removing that old dressing with clean gloves. If I'm doing a wet to moist dressing, oops, go back. Sorry. If we're doing a wet to moist dressing, we want it to still be moist when we're removing that old packing with our clean gloves. If I run into a situation where it has completely dried, it's no longer a wet to moist dressing, it's a wet to dry dressing. If I have orders for a wet to moist dressing and my dressing has dried and I remove it, I'm essentially doing a wet, if I have orders for a wet to moist and it's dried and I remove it, I'm essentially doing a wet to dry dressing. So that's going back to that whole mechanical debridement. If my dressing has dried within a wound and I take it out, I'm mechanically debriding that wound. So it may be taking out dead tissue, but it's also taking out like new granulation or newly healed tissue. So if you have orders for wet to moist and your bandage is dried inside the wound, you need to take a little bit of sterile normal saline and wet it a little bit so you don't cause that mechanical debridement of that wound if you're doing a wet to moist. Applying abdominal binders. They can be elastic or cotton, breast or abdominal binders. Binders are bandages made of large pieces of material specially designed to fit specific body parts. Breast binders are not often in current practice. Sports bras are preferred for breast support after certain surgeries. An abdominal binder supports large abdominal incisions that are vulnerable to tension or stress when the patient moves or coughs. The binder also lessens pain in post-operative patients. Abdominal binders provide a non-invasive intervention for enhancing recovery of walking performance, controlling pain, and improving the patient's experience following major surgeries. Binders support underlying muscles and large incisions, lessening muscle stress, which assists the patient in moving freely without additional discomfort. Managing wound drainage, evacuation, closed drain. We have a Jackson Pratt drain, collects 100 to 200 mils in 24 hours. A Hemovac drain accommodates more drainage, usually 500 mils in 24 hours. The collection device is connected to a clear plastic drain with multiple perforations, and the drainage collects in a closed reservoir. So we have our drain. You'll be able to disconnect it to drain it, And before you reconnect it, you squeeze it down, and that's what's creating your suction that's draining the stuff out of your wound. If the suction starts to lessen, it'll usually happen when the bag is about half full or more. So you would measure your amount of drainage, drain it, and then put the drain back on. Make sure that you depress that balloon or depress the drain before attaching it to the suction or attaching it to the tube, so you create that suction and it helps in the drainage of the wound. So as I'm looking at my person here with the abdominal wound with a JP drain, do I necessarily need more than one person to change this drain? No, not necessarily, because they're laying on their back. I don't, unless the patient's combative, but most of the time, if they're not and they're a compliant patient and they're laying on their back, I don't need any assistance in turning them to change this dressing. The only thing is, like, you would change the dressing and drain the tube. So closed drain, you just vacuum to draw drainage from the wound to the collection device. Oh, and also we want to secure it below the wound, and this is also to help promote that drainage. And we want to be careful with these tubes and with this drainage bulb that we don't lay our patient on top of those, because we don't want to create any pressure injuries. Negative pressure wound therapy. It's the application of subatmospheric pressure. The primary effects of negative wound pressure are at the wound surface. They remove wound exudate, maintain a moist wound surface, reduces edema with the improvement of perfusion, macro deformation, traction on the sides of both wounds, which promotes wound contraction, micro deformation and mechanical stretch on the cells in the wound bed, which change the shape and activates the intercellular process to promote healing. So the application of subatmospheric pressure through suction facilitates healing, collects wound fluid, primarily affects the wound. Primary effects are on the wound surface. The average length of treatment is 4 to 6 weeks. So these are some pretty significant wounds. If somebody needs a wound vac, their wound is probably pretty significant, and the length of treatment is fairly lengthy. So if somebody, it's like, oh, I'm getting a wound vac, this is going to be healed probably in the next week, and I'm going to get to go home. Well, the only thing on that I could see that would require further education on the nurse's part is the length of treatment. Length of treatment is going to be 4 to 6 weeks. It's not going to be a complete quick fix. It is going to significantly decrease the wound's healing time, but it is pretty lengthy amount of treatment. It's 4 to 6 weeks. People can go home with wound vacs with like a home health nurse coming in to change the dressings. So let's look at dressing changes. It's completed every 48 hours, but if the wound is infected, it's every 12 hours. So make sure that you know those. And then we want to look for improvement. If I'm going in and I'm changing this dressing, or I'm the home health care nurse that goes in and changes this dressing every couple of days, how do I know that the treatment is effective? I'm looking for contraction. And what we mean by that is, like, if you see this top picture, it's pretty open, and then we look at the bottom picture and we see it contracting, it's coming together, and it's contracting. So we're looking for wound contraction as a sign of improvement, that our negative pressure wound therapy is effective. Negative pressure wound therapy indications. It's indicated for chronic, acute, traumatic, subacute, and dehisced wounds, partial thickness burns, ulcers, both diabetic and pressure, flaps and grafts, non-viable tissue, once non-viable tissue is removed, and select high-risk post-operative surgical incisions, orthopedic and sternal. Also used with wounds with tunneling, undermining sinus tracts along the wound, and dead space is easily retrieved. Also supported in the use of installation of wound rinsing agents to facilitate healing in chronic wounds. Contraindications to negative pressure wound therapy include necrotic tissue, eschar is present, untreated osteomyelitis, non-extended and unexplored fistulas, malignancy in the wound, exposed vasculature, exposed nerves, exposed asymptomatic sites, and exposed organs. Other safety precautions to consider are patients high risk for bleeding, hemorrhages, patients taking anticoagulants, patients requiring MRI, hyperbaric chamber, or defibrillation. Other safety practices to consider are patients at high risk for bleeding or hemorrhage, patients taking anticoagulants. Research and review of evidence shows improvement of micro blood flow and granulation at a continuous rate of 125 millimeters of mercury. For patients in severe pain, however, they'll have a decreased level of 75 to 80. Recording and reporting. Record the appearance of the wound, the presence of characteristics in drainage, presence of odor. Excuse me. So record appearance of the wound. The wound is beefy red in color. The wound is pale pink. The wound is covered in black eschar. Like all of these different things that we're recording that we just see in the wound are going to tell us a lot about what's going on with the wound. Like if it's beefy red, it's getting good circulation. If it's pink, it's not getting good circulation. If it's covered in eschar, it's probably not going to heal very well until we can debride that eschar. The characteristics of drainage. Is there purulent drainage? That could be a sign of infection. Maybe that wound might need a culture. Is there serous drainage? Is it a lot of serous drainage, like this bloody drainage, or serosanguinous drainage, that kind of clearish to possibly pinkish drainage? The presence of odor. No odor present would be good, because then I'm not suspecting some kind of infection in there. Or if there's a presence of a really bad odor, that wound could possibly be infected. Note patient's response to dressing change. Even if they tolerated it well, you do want to document that they tolerated that dressing change well. Medicated patient 30 minutes prior to dressing change. Patient tolerated dressing change with pain level 2 out of 10. Or patient tolerated dressing change with no reports of pain when asked. So that you're at least medicating your patient and that you are assessing that pain, even if it's a good response. You want to just document that too. Report signs of infection to healthcare provider after obtaining the client's vital signs. So I go in, I change the dressing. It smells terrible. It doesn't look good. There's purulent drainage, and I call the provider to tell them what I see. The first thing they're going to ask me, what are the patient's vital signs? Because they're looking for that elevated temperature as another sign, possibly an elevated heart rate, or possibly an elevated blood pressure. So make sure you obtain the patient's vital signs before reporting signs of infection to your provider. Special considerations. Teaching. Explain expected wound appearance and risks of improper wound care. So if I have somebody and I'm teaching them how to do their own dressings, I'm going to tell them, okay, this is what you're going to expect to see. If you see these things, it's bad. These are signs of infection. And risks of improper wound care, like you need to wash your hands every time before you change your dressing, because we don't want that wound to get infected. Allow patient caregiver to change dressing with and without supervision. So you want to, of course, watch them to know how they're changing their dressing, and then they maybe do it without supervision on days that you don't go change their dressing. If they're able to, you'll watch them and see if they're able to. Pediatric. Obtain cooperation in holding a child. If you have like a toddler or a very small child, mom or dad may have to help hold the child to possibly do a dressing change. Some of our older children, you can distract them by having them watch a video or listen to music. I'm thinking the video might be a little bit more effective. Gerontological, prevent tape from contacting the skin when possible, or use skin protectant. We talked a lot about skin protectant when we need to use adhesive. If you can get away with like doing a dressing change, let's say you have an elderly patient and they have a skin tear, you could put the Steri-Trips on top of the skin tear, but after that you could like maybe use like a zero form, and then use like a Curlex to attach that, and then put the tape on top of Curlex to avoid tape when you possibly can avoid tape on, especially if you can see that their skin is very fragile. Some of our older patients also have delayed wound healing. Home care, select dressing on the basis of the patient's home circumstances. Like if you have somebody who might benefit from a wound vac, but they are non-compliant and they keep turning it off, that might not be the best dressing. You want to select a dressing that the patient's going to be able to use, and if they need to change it themselves at some point, something that they're going to be able to change. Sterile dressings, pets, food contaminate like a sterile area. You just want to be cautious that you have an area that you're able to use. Make sure document required for reimbursement is available. So any documentation that you need to do so that the patient's wound supplies and everything is available for reimbursement. And that concludes the recording for tissue integrity.